meeting. We have a full agenda today, some very exciting things to discuss and report on. So we're going to start off with the minutes of the meeting.
Commissioner Blakeney, unfortunately, we do not have a quorum of CDT members present at this time, but if others do join us, we can revisit this later in the meeting. Perfect. Okay, let's you'll let us know when we get to that point, Colleen. Okay, thank you. Then let's move on to the Quality Measure Alignments Task Force. Staff has been very busy doing a lot of excellent work in this area, and I'm excited to have them present to the committee. So Colleen, if you could help me coordinate with the proper people. Absolutely. I'm going to turn it right over to my colleague, Kelly Hall. Hey, Kelly.
Thank you very much. Good morning, commissioners. Before we hand off to Vivian, let me just note that we have 3 topics today that reflect different areas in which the agency is supporting both care delivery transformation in the Commonwealth. While the topics are really different, there are 2 sort of common themes that run through them. The first is a continued emphasis on applying a health equity lens to all of our work. And the second is the importance of partnership as a strategic lever to advance our shared goals. So in each of these examples, you'll see that the HPC is working closely with partners from sister agencies as well as other stakeholders to work together to amplify the impact of the work we're doing. So with no further ado, let me turn it over to give an example of that work to Vivian Hemme to talk about the Quality Alignment Task Force.
Thank you, Kelly, and good morning, commissioners. I'm pleased to share an update on the EOHHS Quality Measure Alignment Task Force. So I'll start by providing some background. Quality measure misalignment has been a source of administrative burden for both providers and payers. For several consecutive years, we heard in pre-filed testimony that there is a significant reporting burden due to the proliferation of quality measures. According to providers, this reporting burden contributes to provider burnout, it's costly, and importantly, it dilutes quality improvement efforts. In contrast, quality measure alignment has the potential to achieve administrative simplification, sends a clear signal of the Commonwealth's quality improvement priorities, and it better enables us to monitor health system performance. In the spring of 2017, EOHHS, in collaboration with the HPC and CHIA, convened the Quality Measure Alignment Task Force with the primary goal of aligning quality measures for use in global budget-based risk contracts. I'll note that Massachusetts does not presently have a legislative mandate to require the adoption of an aligned measure set, so this effort relies on voluntary adoption by providers and commercial payers. Next slide, please. The task force just completed its 4th year. Participants include providers, payers, consumer advocates, and academic experts, as well as state agency representatives. Undersecretary Lauren Peters chairs the task force, and Michael Bailitt provides expert facilitation. I'll note that the HPC's role in the task force includes providing staff support, having a seat on the task force, and funding the facilitation of the task force and related work groups. The primary goals of the task force are to define and maintain the Massachusetts aligned measure set for voluntary use in global budget-based risk contracts, and to identify measure gaps and pathways for filling those gaps. Next slide, please. The task force began its process by establishing guiding principles for the selection of measures, as well as for the composition of the measure set as a whole. The task force revisits these guiding principles on an annual basis. The task force then reviews measures and endorses them for inclusion through a consensus-based process. The task force initially reviewed over 100 measures and endorsed approximately 25 measures for the initial aligned measure set. Now in its 4th year, the task force has adopted an abbreviated review process to maintain the aligned measure set, by which it adds or retires measures from the set each year. And also every year, the task force makes recommendations to the secretary. And once those recommendations are approved, we prepare measure implementation parameters and specifications, which are disseminated to Massachusetts payers and ACOs for their consideration in contract negotiations. Next slide, please. So this slide includes the tentative 2022 measure set, which is subject to Secretary Sutter's approval. I'll note that the aligned measure set includes both core measures, which payers and providers are all expected to use in their contracts, as well as menu measures from which payers and providers may choose to supplement the core measures. I'll also flag some of the newly added measures this year. So this year, the task force added a maternal health measure on postpartum care to the menu set. The task force also added a health-related social needs screening measure to the menu set. And lastly, they added a health equity measure, which they had been discussing for years and finally were able to add. This measure involves stratification of 3 of the core measures: the HbA1c control, the blood pressure control, and the screening for depression and follow-up, as well as a pediatric measure. And given the present limitations of race, ethnicity, and language data, the task force recommended that this measure initially be pay for reporting only. So all those measures will be stratified by race, ethnicity, and language. Next slide, please. In order to track adoption of the aligned measure set, CHIA and the HPC collect the quality measures catalog on behalf of the task force on an annual basis. As you can see from this table, overall adoption of the aligned measure set has increased over the last few years from 61% to 83%. That said, when looking at trends for individual payers, some nearly doubled their adherence rate, while others have had little change. Next slide, please. To better understand this variation, we conducted interviews with 4 payers as a follow-up to their quality measure catalog submissions. All payers claim to be trying to adopt the aligned measure set, some doing so much more strictly than others. Payers also shared some barriers to adoption, including multi-year contracts, which typically last 3 to 5 years and don't automatically account for changes in the measure set over that time frame, as well as provider request or NCQA emphasis of non-endorsed measures, insufficient denominators, and the burden of collecting outcome measures which rely on clinical data from EHRs. Next slide, please. This year, the task force also engaged in activities to better assess inequities in healthcare quality and outcomes. For the first time, the task force applied a health equity lens to measure review using stratified analyses that were publicly available or provided by task force member organizations. The task force also added a new criteria to its guiding principles to emphasize measures that represent an opportunity to promote health equity. Also, as I mentioned earlier, the task force added a health equity measure to the aligned measure set and is exploring other activities to improve collection of race, ethnicity, language, and disability status data. Lastly, this year, as the task force members complete their second 2-year term, EOHHS will be reopening their procurement this summer for task force participation and will specifically seek representatives of communities of color. Next slide, please. So I'll conclude with some policy considerations for your reflection. First, in the absence of a legislative mandate, adoption of the aligned measure set will likely remain inconsistent. Is there anything else that we could be doing to encourage alignment? Second, there is growing interest across payers, providers, and government agencies to improve collection of race, ethnicity, language, and disability status data in order to surface inequities and quality and outcomes. But efforts to improve this data collection are currently fragmented. Third, the task force presently has had the limited scope of reviewing ambulatory-based measures for use in global budget-based risk contracts. We've previously discussed the possibility of expanding the scope of the task force to either include other measure categories beyond ambulatory measures, such as hospital measures or specialty measures, or to expand the use of the aligned measure set, such as using these measures for tiering purposes or consumer transparency purposes. Lastly, the collection and reporting of measures that rely on clinical versus just claims data remains a source of administrative burden, and it's worth noting that Massachusetts lags behind a number of other states that have already implemented infrastructure to streamline clinical data collection. And with that, I'll open it up for questions or comments. Thank you.
Thank you, Vivian. Are there any questions or comments? I believe we don't see this particular data set very often, but we certainly do want to hear about it and see it. It's very interesting work. Marty.
Thanks, Barbara. I think this work is so important. Since I've been on the commission, this is something that we've talked about on a regular basis, and to see the progress in terms of the number of entities that are moving towards full adoption is great to see. I'm wondering if there's something we can do, when we see places going from 45% to 85% in a couple of years, is there a way to sort of reward them for that level of participation? And my other thought is, do we need to have some direct conversations with those entities that don't seem to be moving and in fact are going backwards in adoption?
Yeah, it's a good question, and I'll open it to others if others want to respond as well. I think we don't currently have a way to quote unquote reward payers. I think we do have our ACO certification program, so we have more of a provider facing approach to this. But I think it is something that's certainly worth considering. And definitely open it up to Lauren if you have thoughts on reaching out to the entities that aren't looking to adopt the measure set.
Sure, thank you, and good morning. Sorry, I was a couple minutes late. So I agree with everything that you said, Vivian, just in terms of without sort of a statutory requirement. And I will note that this is something that the governor included in his healthcare legislation filed back in the fall of 2019 now. But absent sort of that statutory framework in place, there's no sort of formal ability for us to require or incentivize uptake and utilization of these measures. With that said, I think that there's sort of a shared goal of moving towards parsimony in terms of quality measures and the line set. So I think in addition to the ACO certification process, we should continue to be thinking about payers and providers, whether they're participating, understanding what some barriers to participation and utilization of these measures are, and continuing to sort of, I guess, informally promote and move the system towards this measure set until at some point, I think the goal would be to get some sort of statutory language in place so that we do have a better mechanism in place to hold payers and providers accountable for utilizing this. So I would say it's a work in progress, and we should collectively continue to promote and push the system in this direction.
Lauren, thank you for that. I'm wondering as to build on Marty's comment about thinking about some way to reward, would there be a way that we could think about that by simply acknowledging the progress that those organizations who have made progress have made as a way of acknowledging, encouraging, and incentivizing others? Would we need a mandate to do that, or could we find a way to do that acknowledgement minus that?
I mean, I think it's absolutely worth further discussion to think about what that acknowledgement looks like, what form that acknowledgement looks like. So we should certainly discuss ways that we could do that, again, without any statutory mandate or regulatory mandate.
Barbara, it's Chris.
Hi, Chris.
By that, would an example of that be a data point press release from the HPC that says that the following ACOs are really doing it well, and maybe even say that there are a lot of other ACOs that aren't doing it well? I mean, is that what you mean by acknowledging or rewarding?
Well, that would certainly fall within that category, Chris. And Marty, I'm wondering if when you offered the comment, whether you had any ideas yourself as to what that might look like.
Yeah, I think, publicly acknowledging the work that those that have moved the needle. And then, do we need to send Michael Baylett out to Springfield to have a discussion with Health New England?
Maybe we might. Kelly, what are your thoughts on that? And is there a way that we could put our heads together to come up with some ideas that staff might be able to bring back to our next committee meeting to accomplish this?
Yeah, I think we could certainly have a conversation, and obviously would want to engage closely with the task force and with Undersecretary Peters to think through what the levers we have to recognize those who have really gone above and beyond in this work. So would welcome that conversation.
Okay, that's great. And I think we also just need to be aware that this is not solely our committee. And so engaging in the incentivizing would require our continued partnership within this group. So Kelly, thank you for that. And hopefully you'll be able to come back to us at our next meeting with some progress with regards to this that would include our partners in this process. Are there any other thoughts or comments before we move on? Okay, hearing none, then we do now have a quorum. So I'd like to go back and just clean up our agenda by asking if there are any comments, corrections, or thoughts about the minutes of our February 10th meeting.
All right, move to approve.
Thank you. It's been moved. Is there a second?
Yeah.
Okay, thank you. Kelly, do we need to do a roll call? I know we do when the board votes, but does the committee need to, or can we simply accept?
You know what?
I'm going to do a roll call, Madam Chair. I will call it very quickly for you, and I'll start with you.
Thank you. Aye.
And Commissioner Cohen?
Aye.
Commissioner Kreider?
Yep.
And Undersecretary Peters?
Aye.
Back to you, Madam Chair.
Okay, thank you. And with that, again, thank you very much for that report. It's exciting work, and we look forward to continuing our discussion. Our next topic, which I'm going to turn back to Kelly, is inviting narratives on substance use disorder and treatment in the prenatal period. So Kelly, I'm going to go back to you.
Thank you very much. So just by way of brief introduction, for those of you who have attended our last several meetings, and that is all of you, you know that we've discussed our neonatal abstinence syndrome programs, C4SEN, and Beside work. And you may recall that you have heard the word PINQUIN several times. So PINQUIN is the Perinatal Quality Improvement Network. The HPC is engaged in an incredibly productive partnership with colleagues at PINQUIN and the Department of Public Health to advance a number of maternal health and health equity initiatives. The most recent of those is the INSPIRE project. And I'm going to turn it over to my colleague, Rachel Applewhite, to talk about both the nature of this relationship and this specific body of work. Rachel, take it away.
Thank you, Kelly, and good morning, commissioners. So as Kelly introduced, we've had a long-standing relationship with the Perinatal Neonatal Quality Improvement Network of Massachusetts and the Department of Public Health. And just a reminder that PINQUIN is a joint collaborative between the Neonatal Quality Improvement Collaborative Massachusetts and the Massachusetts Perinatal Quality Collaborative. And they're aimed at improving the care of mothers, infants, and families affected by perinatal opioid use. And so the partnership between the HPC, DPH, and PINQUIN has been made possible through funding by the State Opioid Response Grant, which we like to refer to as the SOAR grant, from the Substance Abuse and Mental Health Services Administration to the Massachusetts Department of Public Health. And as Kelly mentioned, we've talked about our NAS investment program as well in our previous meetings. But in 2019, the HPC received SOAR supplemental funding to increase technical assistance and training for providers beyond the HPC NAS investment program and expand and enhance technical expertise to support efforts to develop evidence-based interventions and competencies to serve pregnant and parenting people and families impacted by OUD. And last year in September, we received additional SOAR funding to continue our work and to expand capacity to care for this target population, and also to further understand disparities across the perinatal continuum for people and families impacted by substance use disorder, which is what I'll speak to most in this presentation, which is our INSPIRE project. Next slide. Some of our current deliverables to date with DPH, HPC, and PINQUIN include interventions to improve non-pharmacologic care. So that looks like training and expanding the Eat, Sleep, Console model, which really brings together rooming in, skin-to-skin contact to score neonatal abstinence syndrome. Supporting the biannual statewide summits, which bring together public health, hospital teams, and other state agencies to understand current practices and new research in the space, as well as maintaining the PINQUIN and NeoQuip websites to ensure that resources are available to Massachusetts birthing hospitals for quality improvement efforts. In addition, there are two statewide surveys that PINQUIN facilitates every other year. One is to better understand current practices at Massachusetts birthing hospitals, and the other is to understand provider attitude, knowledge, and skills when working with this target population. And that's to ensure that we can understand gaps and ways to better support or provide trainings to providers in this space. And lastly, the biggest project we're currently working on is to identify drivers of disparities in care for pregnant and parenting women of color with SUD. Next slide. So our INSPIRE project, which inviting narratives of substance use disorder in the perinatal period, a focus on race and ethnicity project, has really been motivated by two different kind of data and research sets. So one of the data sets actually comes from the work from our NAS investment program, which showed that Black and Latinx birthing people were less likely to be using medications for opioid use disorder compared to their white counterparts. And this data is actually consistent with other data sets in the state, which show that there's disparities in any medication use, consistent medication use, and adherence to medications for treatment for opioid use disorder for Black and Latinx birthing people compared to white birthing people. In addition, through our initial SOAR funded work last year, the HPC supported a literature review to better understand inequities in care and access for pregnant and parenting people of color with OUD. And we found through this literature review that majority of perinatal OUD research actually overwhelmingly ignores race and racism in both looking at exposures and outcomes. Next slide. So the goal of the INSPIRE project is to use anti-racist proxies and community-enhanced research, which I'll speak to later in the presentation, to investigate the intersection of race and ethnicity and substance use disorder across the perinatal continuum. The project currently includes experts with lived experience and subject matter expertise to design, conduct, and analyze data from individual interviews and focus groups with pregnant and parenting people of color, but specifically Black and Latinx birthing people, because our current data is showing that that's where most of the inequities lie. And we're hoping to, from these interviews, to identify barriers to care. Next slide, please. So the current INSPIRE project plan uses community-based approach to outreach and engagement with key stakeholders and Black and Latinx birthing people with SUD. We've started this project in October and have been continuously engaging with various communities in Massachusetts, both advocacy groups, clinical teams, and individuals. And then secondly, include individuals with lived experience as experts. So we currently have an advisory team that oversees our project to ensure that we're incorporating our framework and guidelines, as well as reviewing all the materials from the inception, including interview guide, and they'll also be reviewing our outputs over the next 18 months. And that advisory committee is made up of experts with lived experience, clinicians, those from academia, policy, as well as advocacy organizations. The third part is to train peers with lived experience with SUD to facilitate interviews. this was really a key part of this project. We wanted to ensure that individuals being interviewed felt they were in a safe environment to really share kind of their truths and to really share kind of their experiences within the healthcare system. And we can understand that, you know, from research and just known facts that having a clinician or provider ask these questions can sometimes create an environment where individuals feel hesitant to tell their experience, especially if it has been negative. So we just want to ensure that we have the right people at the table asking these questions. And we actually have one peer interviewer who identifies as Black and one who identifies as Latinx. So there's also that peer understanding both race-wise and cultural. We're planning to complete approximately 20 to 30 semi-structured interviews over the next 4 to 5 months. And then lastly, triangulate findings with key stakeholders, including individuals with experience, clinician teams, as well as our advisory team. Next slide. Some of the key outputs from the project include recommendations and proposed next steps to addressing disparities in care for the target population in order to advance best practices in the workforce, as well as a report and analysis on the findings from the individual interviews. This will be a submission both to Pinquin and the HPC, but we do hope that it could be a publication in a peer-reviewed journal as well. And then obviously dissemination of the findings to the community of interest. Through our stakeholder engagement, we've continued to update everyone that we've engaged in, whether it was one conversation or multiple conversations, about the progress of this project, because we know how key that will be when we continue to move this project forward and have outputs. Those are the folks that know their communities best and know how to reach the target population we're hoping to serve. So that's a big part of our plan as well. Next slide. So the INSPIRE project is guided by kind of 4 key principles. So the public health critical race framework, community enhanced research, anti-racist methodologies, and reproductive justice. So I'll just speak briefly on each of these. So the public health critical race framework highlights the importance of describing race as a social construct in critical approaches to examining racial differences and the intersectionality of race with other forms of inequities. Additionally, it acknowledges the pervasiveness of racism, including in the healthcare settings. In community-enhanced research, we're using principles of community-based participatory research, which is an approach that intends to create an equitable partnership and shared decision-making among both community members, researchers, and other thought partners throughout the entire research process. Anti-racist methodologies goes beyond describing and understanding differences around race, but it tends to understand, challenge, and change values, beliefs, and actions that sustain systemic racism. And lastly, reproductive justice is saying that individuals have the right to have children, the right not to have children, but also the right to raise children in a safe and healthy environment. So these are core guidelines and frameworks that our advisory team is holding the entire project accountable to as we move along in this process. And some of the key lessons learned through our stakeholder engagement and our advisory meetings that we've had over the last couple of months include the importance of including individuals with lived experience in the development of the project, conducting stakeholder engagement with various organizations within the same community. While we may have talked to organizations that work in the SUD or OUD space, all of them work with different target populations and can really speak to the needs and gaps in care for some of their populations. And then one of the challenges we came across while building our advisory team and core team for this project was the limited number of Black and Latinx providers and peer recovery coaches, I think within the state, but also nationally speaking, there's a smaller percentage of providers of color. Next slide, please. And so to wrap up our presentation, we've had 2 points of discussion for this. So all the HBC's SUD related work, including the NAS investment program, C4SIN, some of our shift care work, has emphasized the need for peer recovery coaches. And more recently, the importance of those peer recovery coaches coming from communities they serve. And so the question is proposed, what would the HPC be thinking about as a policy level to encourage more diversity in that workforce? And our second thought is, what can be learned from this project about how to include the community voice or diverse representation at the table? Are there opportunities in the near term to rethink how stakeholders are engaged to ensure more voices are being heard? I think both within this project and in the work that HPC is doing in general. So I'll open it up for discussion.
Thank you, Rachel. It's quite a lot to take in, and it's a very ambitious program. Congratulations. Are there thoughts or comments for Rachel?
Just one question for Rachel. This is great work. To what extent have we sort of widened the net in terms of seeking out peer recovery coaches from substance use agencies across the state?
Yeah, so part of our stakeholder engagement, we've talked to both like BSAS at DPH, clinical teams at various birthing hospitals, especially teams that have their own opioid use disorder or substance use disorder perinatal support systems. So that looks like Project Respect at BMC, Boston Medical Center, MGH's Project Hope, as well as the Lynn Community Health Center. We've also engaged in reaching out to some of the Moms Do Care programs, which widely have peer recovery coaches. And so we plugged into different resources that we know about. But predominantly, many of the peer recovery coaches do identify as white. So the ability to find peer recovery coaches who identify as Black or Latinx or other individuals of color, we've faced some barriers there as well.
Thank you, Rachel, and thanks, Marty. Rachel, I've lost track of it. I haven't been as heavily engaged. As I recall, there used to be some homeless shelters that specifically focused on pregnant women. Have you searched that out, or is that a possibility for engagement? Again, I apologize. I no longer know whether those programs are still around or not.
Yeah, that's a great question. So we had a large conversation with a lot of organizations in, I believe, Lawrence, and they plugged us into some of the housing they have for pregnant individuals or their women's housing as well. I think one of them is titled Pegasus House, and there's another one. And so we have been in contact with them, but they're not largely supported by like a peer support system, but they do provide support to pregnant individuals, it sounds like, based on our conversation.
Okay, thank you.
Yeah.
Any other thoughts or comments for Rachel? Rachel, thanks for the good work. We look forward to hearing your progress as the months go on. Very good luck to you.
Thank you so much.
Thank you. Okay, Kelly, I think it's back to you to tee up the MassUP program.
All right, I'm kind of enjoying my Ed McMahon role today, so let me let me see if I can provide a good lead-in. So, as most of you probably recall, a little more than a year ago, we made awards for the Moving Massachusetts Upstream, or MassUP program, which was an investment program aimed at addressing upstream social factors that affect health outcomes. There are many things that are unique and interesting about that project. We could go on and on. There are a lot of things that are quite new for us. Most specifically, because it's relevant to our topic today, the question of how to evaluate a program that is focused so squarely upstream. Fortunately, again, in the theme of productive partnerships, we're able to draw on experience residing in our sister agency, the Department of Public Health, to help us figure that out. project. We have been collaborating with the Department of Public Health on many aspects of this program, most specifically though, program evaluation. And we really are excited to kind of share some early thinking with you about that project. So with that, let me turn you over to somebody you know well, Catherine Harrison, who will introduce somebody you probably don't know at all, Tawei Lin from the DPH. So Catherine, take it from there.
Great, thank you, Kelly. And we can go to the next slide, perfect. So hello, commissioners, nice to be speaking with you again today and focusing on MassUP. So for this discussion, I'd like to introduce Tawei Lin. Tawei is a senior epidemiologist with the Department of Public Health in the Bureau of Community Health and Prevention, and he is leading the MassUP evaluation. As Kelly referenced, this is really a partnership between the HPC and DPH to run MassUP. And Tawei in particular brings a lot of expertise in evaluating community health programs and really the kinds of complex change processes that are at play in MassUP. So most of the balance of this time you'll be hearing from him. But let me just briefly refresh your memory about MassUP and highlight a few reasons why we wanted to have this discussion with you this morning about the evaluation. So as you know, with MassUP, we're funding 4 different partnerships of organizations, all of which include a hospital and a range of various types of community organizations. And these partnerships are undertaking activities to improve a particular social determinant of health, in this case, either food and food insecurity and food systems, or economic mobility and stability. And so they're really all about changing the conditions in communities that influence health and health equity. So, you know, for the HPC, this is really a different kind of investment program. Now, to be clear, we think there's a tremendous amount that we can learn from MassUP and that we can share with our traditional healthcare stakeholders as well as others about what it looks like to do this kind of work. But, you know, rigorously measuring some of the things that we want to learn, you know, really like what makes these kinds of partnerships successful, how effective are their various strategies and activities in actually producing these community level changes. Measuring this is difficult. So, you know, one of the reasons we want to talk with you this morning is we want to share what we're planning so far so that you can reflect back to us whether it sounds like we're planning to capture the kinds of things that you think would be valuable to learn from MassUP, or if you have other suggestions or approaches that you'd like us to consider. Another reason we want to talk to you about this is that, you know, we really plan to approach the process of the evaluation with a very intentional, continuous learning perspective. So, you know, returning data and information back to the partnerships over time and as they go along, so that they too can learn and adjust and improve their work over the course of this 3-year program. So, you know, the evaluation really is fully baked into how we are managing these awards, and it's really just as important now as it will be at the end when we might have a final verdict or a final product to report out. So let's advance to the next slide, and I am going to invite Tawei Lin now to talk you through our evaluation design. Tawei?
Thanks so much, Catherine, for that introduction, and thank you all for inviting me to come speak with you all today. So I'm going to give a fairly high-level overview of the overall approach and design for the MassUP investment program evaluation. As Catherine mentioned and introduced just a few moments ago, the MassUP investment program is a rather complex and unique program. There is quite a bit of heterogeneity across each of the partnerships in terms of their composition, their history of working with one another, in terms of their specific strategies to promote health and economic equity within their communities. And so this complexity has really led us to take a more creative and participatory approach to the evaluation design, which I'm going to describe in a little bit more detail over the next set of slides. But before I dive into the design itself, I think it's important to spend just a few moments to talk about our intentional process to set the foundation for this work. And so throughout the summer prior to the investment program period, the HPC and DPH team held a series of meetings to lay the groundwork for the evaluation. And one key element of that groundwork is really establishing our key principles and values to help guide us as we move forward together. And these key principles and values are summarized here on this particular slide. Catherine already talked about our emphasis on continuous learning and the notion around building enduring partnerships. In addition to that, we also remain committed to principles of community empowerment, equity, alignment, and of course also a focus on upstream structural change. And so all of these values have helped to guide our decision-making process, and hopefully you see them reflected throughout the evaluation design itself that I'll be talking about. Next slide, please. The second key foundational activity that I wanted to talk about is really the development of the theory of change for the MassUP program. The theory of change that you see summarized here not only provides a big picture view of our program, but also establishes clear causal and temporal relationships between program activities and outcomes. On this slide, you see at the most fundamental level how we believe MassUP will bring about community level change. And again, while there's quite a bit of heterogeneity across each of our community partnerships in terms of their individual strategies and targets, the general overarching theory that we have is that if we invest in and build effective, equitable, durable community-based partnerships, they'll have the necessary foundation to change conditions and address root causes of health and economic inequities within their communities, which in the long term will lead to better health and health equity through improvements in the social determinants of health. Next slide, please. So developing the theory of change, at least at that high level, is really useful for evaluation because it provides an organizational structure to guide the evaluation. And so for each of those buckets that you saw in the previous slide, we have these analogous 3 primary components of the evaluation that directly connect to our theory. And so the first component is really the evaluation of the overall development of the community-based partnerships. The second component focuses more on the strategies and activities that the partnerships will undertake to change community level conditions. And then finally, the third component is really looking at the long-term community level health and economic impact that the partnerships will have over time. And within each of these components, there's a more detailed theory of change that we have that breaks down these high-level constructs into more specific components. And I'll be providing an overview of each of those components in the next following slides. Next slide, please. Okay, so diving into the first component, what you see here is our detailed theory for building effective, equitable, durable, community-based partnerships. I know the slide is quite busy. There's quite a lot of information here, but just to highlight a couple of things, each of the boxes in yellow represent a key element that we believe is important in building are these enduring partnerships. And the elements are organized more broadly into 3 general categories. We have resources, partner structure and governance, and partnership activities and outputs. The partnerships theory not only describes how we see MassUP supporting the development of these community-based partnerships, but again, it also provides an organizational structure for the evaluation design itself. And so within each of these particular elements, we have a series of measures and indicators to track progress over time. And to just give an illustrative example, if we focus on the box around clear and unified vision and mission, within that element, we have several indicators that really speak to things like better understanding the process that the partnerships have undergone to establish their vision and mission, to understand the level of involvement that members had within that process, whether partnerships have a clear and unified understanding of the vision and mission, and whether or not the level of alignment of that vision and mission with that of the individual partner organizations. And while unfortunately I don't have the time to really talk through each of these elements today, we are in the process of creating an overall evaluation document that will really summarize and go into more detail into each of these elements, and we can certainly share that with you all if there's interest. And the last thing I do want to highlight here on this slide is that many of these elements and their corresponding indicators were developed in collaboration with our community partners to ensure that they see themselves reflected in this theory and also see themselves reflected in the overall evaluation design. Next slide, please. And to gather data on these various measures, we're utilizing 5 primary data collection methods to gather information in a variety of different ways. So the first is a regular data report where partnerships can submit information related to their local activities and also answer specific questions that we have. The second is a partnership survey, which is a survey designed to conduct a closed social network analysis on each of the partnerships. And the survey itself covers a broad range of topics such as equity and decision-making, clearly understanding specific roles and responsibilities within the partnership, effective communication. And the survey also includes a validated trust scale that we're going to use to measure trust within the partnerships over time. And we just completed our first round of data collection for the partnership survey and reviewing some really interesting preliminary results. And hopefully, maybe at a future meeting, we'll have some opportunities to share with you all some of the information that we're gathering there. The third data source is a series of qualitative interviews with individual partnership members to really provide them with an opportunity to contextualize and more completely explain the data that we're gathering from the other data sources. The fourth is what we're calling these program administration notes, which are basically, these notes and observations that the HPC and DPH staff are gathering during our interactions with the various partnerships. One of the really unique elements of the MassUP program is the level of access that we have to our community partnerships, which we use to try and lighten the data reporting burden on the grantees. And finally, we have a review of partnership documents ranging from communication materials, meeting notes, published materials, and other forms of documentation that we can use to help support the evaluation. So before I move on, to the next two components of the evaluation, I think this might be a good time to stop here and see if there's any clarifying questions or feedback that you all have so far. And I'll open it up to the group.
Thank you, Tawa. You were reading my mind. Are there any questions so far? Well, I think we're okay to continue.
Great, thank you so much. And we'll of course, hopefully have opportunity at the end for discussion as well. So great, so moving on to component 2, which is really talking about the strategies to change community level conditions and address root causes of health and economic outcomes. Next slide, please. Okay, so on this slide is the next component of our theory of change, which really focuses on activities and strategies conducted by the partnerships. So really, what this slide is getting at is once we have built these effective, equitable, durable, community-based partnerships, what pathways can they take to change conditions within their communities? And while each partnership is pursuing their own set of strategies to address root causes within their community, there are a few common pathways that each of the partnerships are pursuing that is in part summarized here on the slide. So for example, if you follow the pathway starting from the blue box at the bottom, which starts at our partnerships and sort of traverse that towards the upper left, we believe that partnerships that comprise of community-based organizations, healthcare systems, resident leaders, they're better able to identify root causes and local barriers together, which allow them to design and lead strategies to address upstream determinants of health. And following the path up the middle, we also believe that partnerships are necessary to align and coordinate complementary social determinants work happening at the community or region level. And then, if you go towards the upper right, we also believe that these partnerships have strength and capacity to advocate for policy change necessary to change local conditions. And in addition to the pathways that are illustrated here, there are, of course, many other pathways that partnerships are taking, and many partnership-specific strategies that partnerships are pursuing related to their own particular social determinant of focus. Next slide, please. And so our approach to evaluating component 2 really looks at evaluation design at 2 different levels. And so the first level focuses on the local partnership identified strategies. And so we are working with each of the partnerships to co-create their local evaluation plans, which includes identifying their specific goals for the MassUP program, and also ensuring that their local data collection methods are able to measure progress towards those goals. And then the second level zooms out and looks at some shared strategies and common themes across all 4 of the partnerships. And at this level, we have identified a few common evaluation domains to identify some measures of success. And to help illustrate this 2-level approach, we're going to take a closer look at one of our partnerships. Next slide, please. And so on this slide, we see the theory of change developed by the Heal-Winchendon partnership. And to just orient you just a little bit, in the middle here is their overall goal for the MassUP program, which is improved health and quality of life for Winchendon residents. And surrounding that goal are 4 primary outcomes of focus. We have social inclusion, economic empowerment, equitable food ecosystem, and collective impact. And then surrounding the gears are their mechanisms of change. And those include building human and social assets, building financial assets, building community assets, and finally building a strong coalition. And so within each of these primary outcomes are a set of indicators that the partnership has developed to measure progress and impact over time. And so, for example, looking at growth in financial capability at the individual and financial level, we have some behavior change resulting from some financial products and services that they're developing. In addition, they'll be assessing the extent to which financial institutions adopt diversity, equity, inclusion practices and policies to begin to address some of the root causes of financial inequities at the organizational and financial level. Next slide, please. And so using that partnership-specific theory of change that you saw on the previous slide, we're able to then map their specific activities onto some common evaluation domains using the socio-ecological model as an organizational framework. So you see the basic socio-ecological model on the left-hand side here. And we see that the Heal-Winchendon program more generally organized into the 6 broad evaluation domains that you see towards the right of this slide, and each having an impact at different levels of the socio-ecological model, and roughly color-coded to sort of see sort of the primary levels that they're having impact. While each partnership will have their own set, a unique set of evaluation domains, there's actually quite a bit of commonality across the partnerships in terms of their domains. And so, you know, if we use these evaluation domains, we can develop a more general set of indicators that we can collect for all partnerships operating within that domain. And then, you know, this will allow us to identify some successes and shared learning across MassUP overall. And again, unfortunately, we don't have a lot of time to go into more detail here, but we do have a more detailed description of each of the evaluation domains and some shared indicators in that evaluation document that we're finalizing and happy to share with you once that is completed. Next slide, please. And finally, we have the final components of the evaluation, which really focuses on improved health and economic equity within communities. Next slide. This component of the evaluation focuses on the long-term expected impact of MassUP. And while the MassUP investment period is limited to a 3-year time window, we certainly don't see the work being limited to this time period. In order for us to achieve the population level impact and the community level impact that we're hoping, partnerships must have the opportunity to develop a long-term vision and strategy that outlives the investment program period. From an evaluation standpoint, it's certainly challenging to try and predict and model some of these long-term expected impacts, particularly for programs that utilize various multi-level and partnership-specific strategies. We don't expect to be able to directly measure this impact at the end of the program period. However, we're working to develop some strategies and approaches to help us predict some long-term success. And some of these strategies include compiling some social determinants of health indicators that partnerships can continue to use and measure progress over time, both within the investment period and beyond. Really clarifying our long-term theory of change supported by existing evidence base for community impact, and also working with the partnerships to ensure that their theories of change include clear connections between the work that they hope to accomplish within these 3 years and also their long-term strategies. And we would also very much welcome your thoughts and expertise on this matter as we continue to work to connect the work of the MassUP investment period to these long-term outcomes. So I believe that's all the material I was hoping to cover. I know that was quite a bit of information to cover over a short period of time, but I'm happy to take any clarifying questions and open this up for conversation.
You're right, Tawe. That's a lot of information in a short period of time. And as Kelly indicated, this is it's probably one of the more complex evaluation undertakings that we've done in the care delivery transformation section of the commission. So, folks, are there thoughts or comments or suggestions for Tawe and our team?
I have a question. This is Patty, because I'm newer to this. We've got the 3-year funding period. Is the anticipation that we will find ways to assess?
Patty, I'm sorry, you're fading in and out. My apology.
Is that better?
Much better, thank you.
Okay, sorry. Because I'm newer to this, I just wanted clarification. I know that we had the initial 3-year funding. What is the anticipation at the end of that period of time, that there will be additional funding available, or that we would help to identify additional sources of funding to continue the mission? If all this work is going into a successful program, you don't want to see it.
Exactly. Kelly?
So at this time, we don't have additional, a path to additional follow-on funding, not at this moment. It's in part because of that we've spent so much time focusing on sustainability and trying to build the partnerships to last, both so that their work can outlive the investment, which is often a goal of ours in our investment programs. But also, I think if on one of Tawe's diagrams, there was also there was a box that was also related to positioning these partnerships themselves to seek follow-on funding. So ideally, if we set the conditions properly, build the durable partnerships, start seeing some progress in the second domain, it will position them well to themselves go out and seek additional funding if it's needed. And I'll invite Tawe or Catherine to weigh in on that as well if you have additional comments.
Yeah, my only addition to that would be, certainly part of our expectation and hope is that, not just seeking additional funding, but also that point that Tawe made of alignment of funding that is already available through whether it's the healthcare system or the various, community organizations that are part of this. That is a goal that we have in MassUP to help these partnerships identify those areas where they could better harness and better make use of funding that is on the table, but maybe dispersed in ways that are less effective as a whole.
Got it. Thank you.
Would we ever provide the technical assistance to help these organizations seek that additional funding, should they need it?
That's a good question. I don't think I have it. We have not considered that, but that's certainly something we could talk about.
Okay, thank you, Kelly. Appreciate that thinking on that.
Question for either Tawe or Catherine or Kelly. How many do we expect to be affecting in Winchendon?
Can you say it again? How many what?
How many do we expect to be affecting through this program in Winchendon?
How many residents of Winchendon do you mean?
Yeah.
Well, I think our unit of analysis here really is the full community level. So the idea in MassUP is we're thinking larger than any particular patient population or sort of subgroup, and really looking at when we think about these kinds of upstream changes, really addressing and affecting individuals through changes in community level conditions. I don't know if that makes sense or gets to your question, but
perhaps the obvious response is if some form of equity with regard to either investment or outcome is the goal, then that implies that we should be focused, right? on those that are less, are getting
Yes.
less resources, right?
Yes, no
So
doubt.
I just don't know whether Winchendon, I don't know the demographics of Winchendon well enough. I suspect that, it may be, 50% below the line, and but I don't know what the financial demographics of Winchendon are.
Can I add in just real quick here? I think this is a really important point, and harkens back to sort of this focus and our commitment to equity. And I think you're absolutely right. And the partnerships themselves have a clear idea of sort of the specific target populations that they're hoping to impact with their various strategies. I think it would be a mistake to, without thinking about at a population health level, without actually thinking about how do we address some of the inequities. And if part of that strategy is a more targeted approach at thinking about what those inequities are and what the root causes are that are causing those. And so thinking about Winchendon themselves, and they would obviously be able to speak a lot better towards their particular strategies, but at each of the various gears that they are hoping to impact, whether that be around equitable food ecosystems or economic empowerment, they do have a very targeted and intentional approach about who are the folks that they want to empower, who are the folks that they really want to reach. And so within each of those strategies, there are some individual level outreach that is happening. There is sort of outreach happening at the community level and organizational level. So it's hard to answer the question in terms of like pure numbers, in terms of like how many they will be outreaching to, but part of the goal of the local evaluation is for us to be able to say something about the specific populations of interest that they're hoping to target, and what was the impact of the MassUP investment program in reaching those populations, and what are some of the outcomes that we've been able to promote.
Thank you, Tawi. I mean, at some point there has to be some kind of model to measure the return. How much did it cost, and what was the impact? Recognizing that a lot of the impact is qualitative, but some of it is quantitative as well. So I guess I've made my point, and I understand your response. Thanks.
Thank you, Jack. Any other questions?
Barbara, just a comment and a question. It's a very, you use the word complex, I'll say sophisticated evaluation. And kudos to the staff and to DPH as well. I guess one question is, to what extent, and it follows up a little bit on Chris's comment, to what extent do we have good baseline data going into these projects?
That is a really great question, and something we've struggled with to a certain extent. I think it's hard to talk about it in generalities because we sort of have our evaluation at a few different components. When we talk about, just very briefly, about some of the challenges, I mean, obviously, the beginning of this program period happened right in the midst of COVID, and the planning for this as the partnerships were applying, that was sort of a pre-COVID era, right? And so thinking about the adjustments that they've all needed to make and we've needed to make has been something that we've been intentional about. From an evaluation standpoint, I mean, I think looking at a population level, measuring change over time is going to be challenging because of, sort of COVID really throws a wrench into all of those things. But I will say that we have really good baseline data on the partnership specific component of the evaluation. That's part of the rationale for the partnership survey and measuring that over time. And so we'll really be able to see at the partnership level what are sort of the things that we've been able to have a direct impact on over the investment program period. I think some of the other components, it's more variable because we have a strong local context specific component to it. Some of the partnerships are being very intentional about the kinds of baseline data that they're collecting. Largely it's qualitative information, but I think, over time we'll just have to be flexible with sort of what we are, and also careful about sort of what we're able to say and how confident we're able to sort of isolate the direct impact of the program But also I think that, over time, because we have this continuous learning approach and this sort of developmental evaluation approach, we will be able to track a lot over time as to sort of how we sort of see progress within each of the components of the evaluation.
Thanks.
Okay, thank you. Are there any other final comments or thoughts? Tawei, thank you for joining us. It's going to be fun having you as a partner with this, and DPH as well. Catherine or Kelly, are there any additional or wrap-up comments that you'd like to offer?
Not on MassUP evaluation. I do want to, since the slide is up, call everyone's attention to upcoming board committee meetings and the advisory council. So we will be seeing some of you again in next month, in July.
Indeed. Well, everybody, thank you, especially to the staff. Your work is incredible, especially given the COVID complications that we've all been working through and with. I look forward to being able to see all of you in person for real at some point, and hopefully the not too distant future. To those of you who have joined us on our YouTube page, thank you for participating with us and listening. And thank you all for your comments and your help. And David Schultz, is there anything that you'd like to say to conclude?
No, thank you, Barbara.
Okay, thank you, everybody. Stay safe out there, and we'll see you again soon. Bye-bye. Yes,
Thanks.
David, I agree.